January 27, 2020. I'm Dr. Ara Duke-Majan, neurosurgeon, CEO, and founder of Duke Spine Institute. We're getting ready to perform a Duke laser disc repair, which is an endoscopic annular debridement, discectomy, and when necessary, decompression. Our patient has a herniated disc at L4-5 and right-sided pain down the right leg. She also has spondylolisthesis at 5-1. And we have the MRI up. Okay, we're going to get started. I'm in the operating room. Our patient is positioned on the table, prepped and draped, ready to go. I'm just going to review the MRI after gowning. Excuse me. I'm going to verify. I see. So we are calling, keep going. So we're calling the listhesis at 4-5. That's probably because of the MRI. There's what's called a pseudodisc embedded at S1, S2. Can we see that on the X-ray? I need you to show me that. You need to be further south. So the listhesis is at 4-5. The pseudodisc is 5-1. Now that's not my nomenclature. That's what the radiologists say. What am I talking about? What I'm talking about is discs are joints. If you have a disc, normally it's a joint. There's movement there. And yeah, I see it now. You can see on the X-ray that we just took that there's a disc that the radiologists are calling L5S1. That is not the disc we're operating on. The next disc above it is pretty wide, normal caliber, normal height. That's what we're calling L4-5. There happens to be a listhesis there, which is a slippage. So we got a nice open disc space with listhesis, and there is some sclerosis of the bone, which is thickening of the bone, so it's darker on X-ray. So we're getting ready to get started. Are you comfortable? This is Dr. Duke-Majan. We're getting ready to get started. Everybody agrees it's right? L4-5? All right, Dr. Duke, we're going to get started. That's my hand on your back. It's important you lay still. Just lay down and rest and be comfortable. I only need you to talk to me when I ask you a question. If you feel pain, just say ouch, and I'll know to stop what I'm doing and make you more comfortable, okay? That's my hand feeling your back right now. I'm feeling for the right place to put some numbing medicine. You're going to feel a little stick and burn. That's normal. That's just the numbing medicine going into your skin, okay? Everything's okay. I'll let you know if we have any problems whatsoever. I injected 5 cc's. All right. Just lay still, okay? All right. So step 1 is positioning, prepping, draping. Step 2 is what we're doing now, where we're actually trying to get down to where we need to be. Shot? It's an incredible amount of sclerosis. You comfortable? I need a lateral. So what you're seeing, folks, on the X-rays is a front view, and now we're going to switch to a side view. And by doing the side view, it allows me to see kind of the trajectory. This is too close to me. This is too close. Yeah, that's fine. Lay still, okay? You're doing really good. I need you awake just for the very beginning. Shot? 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 Shot. Shot. I'm getting through all the scar tissue associated with the listhesis right now. There's some extra bone in here because the bones have hypertrophied. They've gotten bigger as a result of the injury to the spine. Now we're not here to fix a listhesis. The only way we can fix that shot is with a open fusion surgery. We're here to take away her pain without having to do open major surgery. Shot. And our best chance of that happening is this procedure we're doing right now, endoscopically. Shot. AP. And I can feel the needle being deflected by some of that extra bone over there. And the bone is always going to deflect the needle laterally away from the spine. The question is how much deflection is going on. And is it too much or is it okay? So that's what I have to figure out right now. There's a little bit of deflection, maybe 5 degrees, 8 degrees. Go ahead and go lateral. Well, let's see. And if it does get deflected more, then I have to change my angle, trajectory angle, which means I have to start in a different place. Are you comfortable? Your neck's a little sore? Yeah, you can turn your head. Just talk to the anesthesiologist, and he's going to work with you to make it more comfortable. Where do you feel that? Where do you feel that? Yeah, that's what I was afraid of. Is it better? So the way that it's gone, let me have a little bit more local. I'm going to try a little bit different. Are you comfortable now? All right. What's the problem? Right. So I'd like to start a little bit higher and a little bit more lateral. Remember, just let me know if it's hurting you, okay? Shot. Shot. Can we, actually, I think we're okay on the wag. Is she all right? Yes. Shot. Shot. I can feel all that posterior element that's hypertrophied as a result of the listhesis. Shot. It's just getting through this mass of kind of scar tissue and thickened bone. Honestly, didn't expect her to have much in the way of. That hurts in your back. Shot. In the lower back. Yeah, let me give you some more medicine. I'll give you some more medicine to make you feel better, okay? We certainly don't want to inject any of this near the nerve root. But we're not near the nerve root, so we don't need to worry. But obviously injecting near the nerve root could cause this patient's leg to fall asleep, so to speak. And we really don't want that. Shot. What she's having is a little discomfort from the muscle where I'm passing through. Shot. We're really close. Where do you feel that? Your back, right? All right. Everything's okay. Just let me know if you feel it anywhere else. This is the herniation right here. I can feel it. Yeah. We're almost there. You feel it in your back anywhere else? Just the hip? All right, don't move though. Remember our agreement. You don't move and I'll make sure that I do everything well. Is that a deal? Are you comfortable? Yeah. What's your biggest problem? Remind me, is it your back or your leg? Both? Equal? Yeah. All right, are you comfortable? Yeah. Good. How bad is that on a scale of 1 to 10? 10? Is that where you typically get your pain? All right, we're going to put you to sleep. I found the bad disc. The good news is I found the bad disc, okay? So we're going to put you to sleep. When you wake up, that pain will be gone forever, as long as you don't re-injure it. All right, count from 1 to 100 out loud. Keep going. All right, so what happened? I accessed the disc so that I have a surgical path, a corridor, a way to get down to the disc through the foramen. Notice, did we take any bone out, folks? No. Every other spine surgery done out there besides the Duke laser disc repair, endoscopic transforaminal surgery, is done by removing bone. The moment you start taking bone out of her spine, that slippage is going to get worse, and she's going to become unstable even more. She's going to need a fusion. So this patient is avoiding a fusion by having the Duke laser disc repair. That's the only way you're going to avoid a fusion. That's why this surgery is so much better, because it can take the place of a fusion and repair the pain and the irritated nerve, but without doing open surgery. It's the only place in the world you're going to find this surgery is at Duke Spine Institute. So once I got access into the disc, right where the pain is coming from, I kind of knew that ahead of time based on the MRI, but more importantly, based on where she was pointing that her pain was. So once I knew where her pain was, when I examined her in the office, I could see where her pain was coming from. I knew it was the L45 disc, I guess we're calling it. Huh? Yeah, we're good. I'm just talking. She all right? All right. So I knew that I believe that disc was the problem, and I just tested it now with what's called a discogram. And the discogram is where you inject a little bit of dye into the disc. And by doing that, I reproduced her typical pain that she usually gets in her lower back. So that's a confirmatory test that tells me we're in the right spot. That's the source of her pain, is that disc. Now, if her pain was coming from a facet joint, it wouldn't activate like that, okay? So by doing that test on the disc, the herniated disc, I found that herniated disc is indeed the cause of her pain. So we make a little incision with the number 11 blade, and now I'm going to bring the dilator down. Remember, the dilator is this long metal pencil, and it's got a place for the guide wire to go into and come out the back end. And it basically just spreads the tissue gently, okay? So when you do spine surgery and you're dealing with the muscles and the tissues, you want to be gentle, very gentle. As a matter of fact, it's the muscles that cause the pain after spine surgery that people have in their back after a spine surgery. It's the muscles that are inflamed and angry. So by not damaging the muscles, by using a skinny, narrow tube, I can actually get down to the disc to fix it without hurting the muscles. And by following this guide wire shot, I mean, I can feel the herniation. By following the guide wire, I know that I am going down a safe path that I created earlier using the needle. Man, that thing is big. Shot? That is way out in the foramen. So I think she's going to be happy, but there is definitely a big herniation out in the foramen. So you don't really see it that well in the MRI. But I think she's a little rotated too. So what looks like far away from the disc is actually not that far. You ready for some stimulation? Are you comfortable? Shot. You're doing good. Just stay still. You want me to wait? Coker. You're okay. Shot. You're okay. Everything's fine. You're doing good. Just hang in there. Shot. Yeah. You're doing good. Just lay still. All right. Let me bring it back a little bit. Yep. Other way. That is not how my hand is going to hold it. Shot. That's good. You can see the offset of the vertebrae. Why don't we try to fix the vertebral offset? You want me to wait still? Doc? I'm not going to wait a minute because I want to try to adjust the floral picture a little bit. All right, try a little bit. Let's see what happens. Gosh, I can't really tell. I almost feel like that's worse. Try the other way. That's good. I think that's really good. So what happened is the spine is kind of twisted compared to our floral plane, where we're shooting an image through the patient, through that area that we're looking at, which is the L45 disc. We're actually, you want to go straight through that area, but if the spine is relative to the floral plane is offset, then you're going to get some weird looking anatomy, and you can actually might think you're somewhere where you're actually not. You're somewhere else. So it's very important. I can't over stress how important it is for a surgeon to make sure. Shot? Want me to wait? Yeah. The surgeon has to be like very confident in where you are. And the only way that's going to happen is by having really good pictures, floral pictures. And the only way that's going to happen is if you have a good fluoro machine and you have a good tech and you have the anatomy lined up perfectly, okay? So sometimes you have to position the fluoro machine, like reposition it. And the fluoro machine is able to adjust the plane of the x-ray in 3 dimensions. So we can go up, down, left, right, wagging. We call wagging. And by doing all that, we can line up the fluoro machine plane perfectly with the axis of the foramen where we want to be. Okay? But the reason I'm talking about it, folks, is because a lot of spine surgeons don't take the time to line things up properly. And then you can get into trouble because we're working in safe zones around the spine that have only 1 millimeter or 2 safety around them. So if you're off by 1 millimeter or 2, you could cause serious damage to the patient and really hurt them. So you really want to make sure that you know exactly where you are and that you're in the right spot all the time. Okay? So you can see I'm bringing the endoscope down. Sean, you want to show them real quick the endoscope?
Sure, we can see it.
All right, so this is the tube that I work through. It has a lens system. It has light that goes through it and comes out the end. Okay? It also has a place for me to work, a channel. She okay? And there's irrigation that goes in as well. All right, so there's the disc. We know for sure this disc is the source of her pain, no doubt about it. I'm going to bring the laser in. And you can actually see that most of the surgery that I do is based on the laser. About 95% of it. So the surgery that I'm doing is true laser surgery, as opposed to a lot of the other places that advertise lasers but don't know how to use them or don't use them at all. The reason I use the laser is because the laser truly is more effective than normal surgical instruments that we normally would use in spine surgery. Those big instruments, the metal instruments, can't do the very fine work that I do with the laser. So if you look here, the laser fiber itself, the glass coming out of the end, is half a millimeter wide. Half a millimeter. You all know what a millimeter is. It's that space between your fingers where you barely have light coming through. You can make it small enough. She's moving a little bit. Standby laser, wipe, I guess. Wipe. Yep. It's a little blurry, but it's also not just blurry, it's from some of that blood. Little vein bleeding. Somebody asked me about the last surgery. Yeah, she's responding a little bit more than I want her to. So I don't know if you want to use some fentanyl. No, that's right, it won't work. The lady from the last surgery, I got a question afterwards. That little vein that was bleeding, is that going to be a problem? The answer is no. The veins look big to us because we're using a scope. Everything looks big. The reality is that it's small and tiny, and the amount of bleeding coming out of it is insignificant. Not just the blood loss standpoint, from a bleeding standpoint. But because of those veins that bleed, you can understand why our patients have to be off all of their blood thinners, non-steroidal anti-inflammatories, before surgery even takes place. Okay, it's very important that they are, because a little vein like that will stop bleeding normally. But if you're on antiplatelet therapy or if you're on anticoagulation therapy during the surgery, it could bleed and not stop bleeding. And that would be really bad. Now we do have a few tricks we can use. We have thrombin. We could pour down the tube if we needed to. We even have gel foam. We could pack down there if we needed to. But truly we don't need to, because it's just not necessary. How's she doing? We should be done in about 8 minutes. Huh? She does? Such a thin lady? She's thin. Just a thin lady. Does she have her tonsils and adenoids taken out or no? Yeah, I never got mine taken out. My dad was a doctor. He didn't want me having them taken out for no reason, you know? It's weird. Right? Why is that? Well, so your mom had an opinion about it, obviously, right? Isn't that weird? I don't know what my dad was afraid of. Maybe he was afraid of the anesthesia, you know? The potential complications. This is back in the 70s, so things were a lot different back then. All right, so what I'm seeing is that this disc is pretty scarred up from chronic inflammation. It's nothing that I didn't expect. That's kind of what I expected here. I knew that this was going to be pretty scarred up. This is all the herniation just stuck inside the annular tear. All the white stuff is scar tissue inside the disc. How do you get scar tissue inside the disc, right? Some people are thinking, well, you don't have a blood supply, so how do you get scar tissue inside the disc? Simple. Scar tissue grows. It doesn't stay where you want it to. It travels to wherever it wants to go. And quite honestly, scar tissue is going to go, let me have a pituitary. Scar tissue is going to go where the inflammation is. So, yeah. So what happens is the outer annulus gets torn, right? The nucleus squeezes out like a piece of toothpaste coming out of that tear, and that elicits an inflammatory response in the outer annulus where we know there's blood vessels, blood supply. So would it surprise you if you knew that the outer half of the annulus did have a blood supply? Would it surprise you to know that there was inflammation happening in the outer annulus? It shouldn't, is what I'm getting at. It's expected. If you have an injury to the outer half of the annulus fibrosis, the part nearest the nerve root, you're going to get an inflammatory response, period. Every single human being will have that. The problem, though, is that the nuclear material is wedged in there. And as the inflammatory response begins, it expects to end after a few days. But it keeps going because as it starts to do inflammation in the outer annulus, the nuclear material wedged in there starts breaking down too. And as the nuclear material breaks down, it creates more inflammation. And as you get more inflammation, more blood vessels come, and they start to grow into the annular tear to try to repair it, basically. And as it does that, the scar tissue gets deeper and deeper into the disc. As a matter of fact, there was a neurophysiologist, neuroanatomist, Swedish, I met in my lifetime. He was a bit older than me, but I met him a good 12 years ago. And he showed in dead people, he sliced their spines open and looked at their discs. And he proved that scar tissue can grow inside the disc, all the way to the center. Well, you can't have scar tissue if you don't have a blood supply. It's impossible. So the only way scar tissue can get to the center of the disc is if the center of the disc had blood supply. The obvious reason why is you could see it growing from the periphery of the disc into the center of the disc. That's how it happens. And that inflammation is driven by the annular tear and the herniation. But most specifically, if you go in and remove the herniation and you treat the annular tear, you can get rid of the patient's symptoms. And that's what the Duke laser disc repair does. And I apologize for this red afternoon, but that is just a little bit of venous bleeding. It's not going to be a problem for the patient. It's not a problem for me because I know what I'm doing, fortunately. I can't do this surgery with my eyes closed, but pretty close. I know where everything is and how to do it properly. So thank God for my experience of doing this many times. I don't have to see everything perfectly well to know what to do and not to do. But I'm in a safe zone right now where I'm working, and this is all herniation right here, the blue stuff. So I'm just using the laser to zap it all away. Herniation and scar tissue. The nerve is being protected by the retractor. So as long as my retractor doesn't move, we're going to be fine. She's a bit uncomfortable. Only because in people with chronic pain, narcotic medications don't work the way they would in somebody who doesn't take painkillers all the time. But when you take painkillers all the time, you can get desensitized. So the pain medication doesn't work as well for people who have been on painkillers for a long time. And unfortunately, a lot of my patients come to me because they've been in pain for a long time and they want relief. I mean, the good thing is they want relief and they came to the right place. The bad thing is they've been in pain for a long time. So it changes their receptor makeup. It changes their physiology of their receptors on their cell membranes with respect to opioids usually. And they can actually be desensitized and develop tolerance. Tolerance comes from, most people don't know this, but it's a downregulation of receptors on the cell surface. So the cells that respond to opioids for pain control, they have on their surface little proteins, glycoproteins, that almost done, that bind to drugs and other molecules that are floating around in the extracellular interstitial space. And when you have chronic use of anything, including narcotics, you're going to get a downregulation of those receptors so that the medications are not as effective in a person who uses them all the time. All right, let me see what we got here. All right, there's medial standby laser. Let me just see where we are. So in the case of those types of patients, yeah, let me have a little more laser. In the case of those types of patients where we can't use narcotics during surgery really to control their pain, we have to use a little more fentanyl and local. I'm sorry, not fentanyl, but I mean propofol and local. Just about done. One minute, and we'll be done. Stand by. All right, we're done. Well, I don't think that was any easier than any other case, to be honest with you. It was a little difficult just getting to where we needed to be, but I feel that we got done what was necessary. And once again, we're not fixing the slippage. That's going to require fusion. And what I found over the years is that most patients, they don't want a fusion. And I don't blame them. They want something else that's less invasive. The Duke laser disc repair, as you can see, we don't put any metal, we don't put any bone, we don't put anything unnatural that we leave in the spine. We just put that tubular retractor to do the surgery, and then we come out and we're done. EBL 5 mil. So we're putting a little pressure on the muscles because muscles are very vascular. They have a lot of blood supply. So we go through the muscle and we don't cut it or anything, but sometimes you'll tear a little vein as you're passing through. And that vein can actually bleed. But it bleeds under about 12 millimeters of mercury pressure. Put some pressure here. So what we have to do is we have to put pressure against the vein for about 3 minutes while the vein closes off and then stops bleeding. All right, any questions for me?
There have been no questions so far.
Oh, everybody knows everything. Done a good job of teaching. All right, I'll head over to the conference room. If you do have a question, feel free to type it up. And I'll answer it for you.
All right, everyone, thank you for joining us back for the post-op Q&A. We have a few questions queued up for Dr. Duke, and Dr. Duke is in the room with us ready to answer them. We'll begin with our first question from a viewer on Facebook who asks, what treatment is recommended for nerve damage? I'm currently taking pregabalin and I'm hearing bad things about the side effects.
Okay, great. Well, thank you for asking questions. This is Dr. Ara Dukmajian, CEO and founder of Duke Spine Institute. We just finished with a Duke laser disc repair surgery. And I'm here with Sean. And just to clarify, Q&A is not quality assurance. It's question and answer time. So if you have questions, type them up and I'll answer them for you. First question was from one of our viewers asking about nerve damage and how you treat it. So I never answer questions just yes or no because, to be honest with you, I try to think about all the people that could benefit from the answer to this question. And basically, what it comes down to is there's many different kinds of nerve damage, and the kind of nerve damage you have is going to determine what the best treatment option is for you. So let's talk about what I think is one of the most common forms of treatable and curable nerve damage, and that is a pinched nerve or an irritated nerve in your back or neck that causes pain to go down your leg or down your arm if we're talking about the neck. And it also can cause numbness in your arm, forearm, hand, numbness down your leg and your foot, weakness, pins and needle feelings. So nerve damage can be due to pressure on a nerve from a herniated disc or a bone spur, or from a variety of other things that are complicated and I don't want to get into, that involve bone spurs off the facet joints and large facet joints, capsule enlargement, ligamentous buckling. So those are some of the common causes of nerve compression. So nerve compression, nerve damage is probably the best one to have because you can fix that nerve damage very easily. It just takes the right kind of surgery. Duke laser disc repair is the perfect surgery to unpinch nerves and stop the nerve from being damaged more. So endoscopic Duke laser disc repair, the surgery you just watched, is the number one choice. Other choices would include a fusion surgery with a decompression, and other types of surgery would include like a microdiscectomy, which I don't recommend because microdiscectomies are barbaric. Your surgeon has to remove a lot of bone from your spine, particularly your facet, F-A-C-E-T joint, which is going to weaken and destabilize the spine in order to be able to take out the herniated disc. So, number one cause of treatable nerve damage is spinal stenosis from herniated discs. Best treatment in the world, Duke laser disc repair. Other treatments include laminectomy infusion, microdiscectomies, etc. But those all involve massive collateral damage, long recovery, and high risk. So the best, endoscopic surgery. Another type of nerve damage would be something called neuropathy. And neuropathy comes about from chemical damage to your nerves. And it doesn't affect big nerves. It affects small little nerves, fine nerves. The most common cause of neuropathy in the world is diabetes, at least in the United States. In diabetes, what happens is your sugar in your blood is too high, and that high sugar gets into the nerve, and it causes swelling inside the little nerves, and it causes nerve damage. That nerve damage can be diagnosed clinically as burning in the hands, burning in the feet, and numbness in your stalking area of your leg from your mid-calf down to your feet. So numbness in the hands, numbness in the feet, burning in the hands, burning in the feet. We call that peripheral neuropathy. And again, there's a list of about 50 different causes or even more. The number one cause of all those 50 that's known is called diabetes. Really the biggest cause that takes up 30% of all the causes is something called idiopathic neuropathy. And that basically means that the doctors don't know why the patient has that neuropathy. Yeah, neuropathy is kind of an endpoint for a lot of different diseases, whether they're vascular or metabolic. And neuropathy can even happen with things like Agent Orange. So if you're in the military, you got exposed to Agent Orange. That Agent Orange material that we use to gas our enemies, that Agent Orange material got into our own troops and caused permanent nerve damage called neuropathy. All right. So how do you treat neuropathy? Well, the most important thing to do is figure out why you have it and stop that reason. If it's diabetes and high sugar, get your sugars down, get them under control, get them where they need to be. If your neuropathy is due to a thyroid problem, then get your thyroid fixed. If it's due to steroid use, then stop using the steroids. So really what it comes down to is you need a neurologist who's going to sit down and figure out why you have neuropathy and treat it properly. All right. Now, that's step one in treating neuropathy. Step two is getting rid of the symptoms of burning and pain. So what kind of things can be done? Well, there's creams that can be rubbed on your palms and feet. There's medication you can take like Neurontin, gabapentin is one example. Lyrica is another. And these medications, and Tegretol is another, they basically stabilize your nerves so that your nerves aren't firing all the time like they are with the pain and neuropathy. Nerves are constantly firing abnormally. So these membrane stabilizing drugs are very popular and very good in most patients to help alleviate or remove the symptoms of neuropathy. All right, another treatment is something called the spinal cord stimulator. It's a surgical treatment, and it's basically putting an electrical pacemaker with wires over your spinal cord. This is done by many doctors around the world. We do it at Duke Spine Institute when we don't have any other options for patients. And that spinal cord stimulator is very effective in about 50% of the patients that have this type of pain at blocking it. All right, what's another option? Herbal remedies. Herbal remedies, the one that I've heard that works quite well is turmeric. I've heard that people that use turmeric, they boil the root, they drink the tea, it actually helps with their neuropathy symptoms. So just forest from the tree, how do you treat neuropathy? Figure out why you have it, get that fixed so it doesn't get worse. Then number two, how do you treat the symptoms once you have it? There's medications you can take by mouth, prescription. There's herbal remedies. And then there's surgery with a spinal cord stimulator if all else fails. Okay? And there's creams you can put on your hands and feet. Now, what other kind of nerve damage is there? There's also nerve damage from damaging a nerve. Okay? For example, you get into a ski accident, break your leg, your fibular head snaps, it damages your common peroneal nerve. Now you have weakness in your foot, numbness in your foot. So there's all kinds of stories like that. Alcoholics who get drunk, fall asleep on the park bench, they sleep with their arm hanging over the edge of the bench. They get a C7 neuropathy. So there's nerve damages from compression, which means pressure on the nerve. Depends on the circumstances, but a lot of times that nerve damage gets better. It just takes time to heal. And then there's those that don't heal, and they're too severe. So it just depends. Those you just allow them to heal. You give it time. The nerve grows at 1.4 millimeters per day. That's not very much. So you're going to have to wait a long time for the nerve to heal. Okay? So there's different types of nerve damage. I've tried to give you an overview of a few of the major types. Neuropathy, peripheral neuropathy, motor sensory, metabolic neuropathies, and then pinched nerves that are actively being pinched and damaged that can be fixed with surgery like the Duke laser disc repair. So to answer your question, whoever asked the question, I would really need to know what kind of nerve damage you had. I need to know, was it as a result of an accident or something that happened suddenly? Have you gotten any improvement? The fact that people improve with nerve damage, there's improvement, is a sign that it's reversible. It can be fixed. So no improvement whatsoever is a bad sign. Improvement is a great sign, and you really want to let that nerve heal. If you have anything more specific for your particular case, reach out to Duke Spine Institute. Just so you all know, I want to let everyone know once again, Duke Spine Institute offers not just free educational broadcasting, answering questions like you've been watching, but we also offer a free MRI review. If you have back or neck pain or know somebody with chronic back or neck pain, we're happy to help you. We do a free review of the MRI with some recommendations if you want to take them. We're happy to see you here and treat you here as well. But we realize a lot of people can't make it to Florida to get treated. So we try to help guide people over the phone with a teleconference, a Skype call, and that way I can guide people. We do all that for free. We don't charge. It's just part of what we do for the community, for the world. The other thing I tell you is we do have an app, Duke Spine Institute app, for both Apple and for Android platforms. So no matter what computing system you use for your phone, your computer, your watch, we have an app that you can download for free. Go to your app store, look for Duke Spine Institute. You'll find the app, download it, and use it. It's full of very useful information. It allows you to connect with our practice and our doctors, ask questions, get a free Skype conference to ask questions, also upload your MRI. It allows you also to participate in the surgeries. So I recommend you check out the free app. And we have a Facebook support group called the Spine Surgery Support Group. I recommend everybody join. It's free. We don't charge for it. And if you post a question there, you'll get an answer, and it's free. So if you know somebody who needs help, have them post their problem, and we'll do our best to answer it. There's also other really good people in the Spine Surgery Support Group. We've got over 200 members, and I can tell you there's a lot of good interaction going on, a lot of good advice. All right, what's the next question?
Our next viewer is also from Facebook, and they are wondering, I've been told by my neurosurgeon in the UK that back pain cannot be cured unless you have leg symptoms. Otherwise, surgery will have no effect. Is this true? I don't know what to think anymore.
Well, first of all, thank you for asking a question from the UK. We do have patients from the UK who come here quite often to have their back pain fixed. And I think that Sean must have uploaded the surgery we just did this morning. This is a lady who is 82 years old. She's had chronic back pain for, she says earlier this last year, so about 9 months ago, but she's had pain on and off for years. She had no leg symptoms whatsoever. Watch the interview. Have you released it yet? Yes. We just posted it. It's on the Duke Spine Institute page, and it's also on the Spine Surgery Support Group. It's the latest video from this morning if you watch the first surgery. She had 3 herniated degenerative discs. She was told that she couldn't be fixed by many doctors. She was told by a spine surgeon she needed a fusion. That was the only way to fix the pain. She came here. She had Duke laser disc repair. Her back pain, 100% gone. 100% gone. We have literally over 1,000 of these surgeries done in the last 13 years, and 95% of the back pain is gone in all those patients on average. 95%. I've never had less than 50%, and I have a lot of people, 1/3, with 100% back pain relief. So what you're hearing from your surgeon in England is not true, but don't feel bad. Many people around the world are told by their doctors that their back pain cannot be cured with surgery. It is absolutely not true. It's true that the surgeon in England cannot cure your back pain. You're right. But it's not true that nobody can cure your back pain. It is curable. Thank God it's curable, and I found the way to cure it. I'm Dr. Ara Jigmajan at the Duke Spine Institute. It took me years to figure it out, but once I figured out what's causing the back pain, we're able to fix it. And I'll be honest with you, you know, of all the people that come to Duke Spine Institute and here in Orlando, Florida, to have their back fixed, probably 25%, 1 out of 4, has only one cause of back pain. The other 3/4 have at least 2 different reasons for back pain. But we are able to treat all causes of back pain here at Duke Spine Institute. So don't be afraid. When we see you, we're going to figure out why you have back pain. Is it your facet joint? Is it your disc herniation? If it's your disc herniation, is it 1 disc herniation, 2, 3, 4? And I can do all of that by doing an exam and ordering tests. So within 24 hours, we could figure out why anyone has back pain and within 48 hours we can have the back pain cured. That's what we do at Duke Spine Institute better than anyone in the world. So you're right, your surgeon cannot fix your back pain in England, but we can here at Duke Spine Institute. That goes for anybody out there that's been told by their doctor, by other people, that their back pain cannot be cured. We cure back pain all the time, every day.
All right, our next question also comes from Facebook. We have a viewer asking, I've been prescribed morphine tablets because of the pain from 2 herniated discs and a broken facet joint. I have severe pain all the way down to my feet. Will the morphine be enough to help?
Okay, well, first of all, I'm sorry to hear that you're suffering, and I appreciate you being here and asking questions. So, look, the reason I sit here and answer questions for you all rather than surf the internet and enjoy myself is because there's so much misinformation, unfortunately, out there in the world about back pain and neck pain. And I feel that God has put me here for a reason to educate people about the truth. And I truly believe that God's given me the ability through my relationships with my employees, such as Sean, Sonny, all the people that help me to fix people's pain are all in place for a reason. They're here to deliver a message. And that message is very simple. Yes, years ago we could not fix back pain. Years ago we could not fix chronic back pain. So if you had back pain lasting for months or longer, you're pretty much doomed to live with it the rest of your life. Thank God there's been improvements in surgery technique. Thank God there's been the development of endoscopic spine surgery. Thank God there's better anesthesia now than there was 10 years ago. All these changes in the field of spine have helped doctors like me to be able to cure patients with chronic back pain. The problem that we're encountering, you're encountering, and many others like you, is a broken system. It's a system that is so damaged by the insurance company's greed that it's virtually unrepairable at this point. But I'm not asking you to give up. I'm telling you to fight for what's right. What should be happening, folks, is this. Doctor like me discovers a cure for back pain. I present that cure to all the neurosurgeons at the big meeting in Los Angeles or San Diego, wherever it is, or England. The surgeons come and say, oh my God, this is great news. You've done something wonderful. Thank you. Now teach us how we can do this for our patients where we live. But that doesn't happen, okay? And here's why it doesn't happen. It doesn't happen for a multitude of reasons. And not any one reason is more important than the other, but it's a variety of reasons. And I've seen this over many, many years. It's borne out to be true. Number one, surgeons don't like to admit that they don't know something. They all get done with their training and they think they know everything. So learning something new is almost too much. It's just too much for them to accept, for their egos to accept that there's something they don't know. I accepted it. I didn't learn this in my training. I got done with my training. I got done with literally the #1 neurosurgery training program in the world, University of Florida in Gainesville, with Dr. Albert Roten, Dr. Arthur Day, Dr. William Friedman, Parker Mickle, Glenn Rectine, I won't say Pat Jacob, but Dr. Stephen Roper. All right, we had Rick Fessler. These are the top names in neurosurgery in the country. We had some of the top neurosurgeons. I was trained there for 7 years. Not once did I learn about endoscopic spine surgery. I learned about endoscopic brain surgery, but I didn't learn about endoscopic spine surgery because nobody was doing it. I didn't learn about pain generators and what causes pain because nobody knew. So there was a time, it didn't matter how good your training was, you were not going to be able to cure back pain. But that's changed. I got done with my training in 2004. In 2004, I had probably more knowledge than most of the neurosurgery residents about curing pain because I learned from one of my attendings, Jeff Henn, who trained at the Barrow Neurological Institute in Phoenix, one of the top training programs in the world as well. And Jeff Henn was a specialist in degenerative spine conditions. And I literally did surgery with Jeff every single day he did surgery because I was in a position to do that being the senior resident. You get to choose first. So long story short, I spent 2 years really working with Jeff Henn every single day doing spine surgery. And what I learned was that back pain and neck pain are curable. Curable. But at the time, we were curing it with fusions. Fusions done properly, which unfortunately most spine surgeons don't do their fusions properly. Only about 2% do. So that's why there's so much chronic back pain, because most doctors can't cure it. They're not trained to do it. They don't know how to do it. They don't know that it can be cured. So the reason why in 2020 there are still doctors out there telling you that your back pain can't be cured is because, number one, they don't know that it can be cured, and if you try to tell them that it can, they're basically going to not believe you because they don't want to believe it. They weren't the first ones to figure it out, and they weren't taught that in their residency, so they're not going to believe it. So it's called skepticism, understandable, but when you have skepticism to the point that it's harming your patients, it's time to ride off into the sunset and hang up your hat. The second reason that this information about back pain being curable is not available everywhere is because the insurance companies that pay for surgery, they don't want people getting back and neck surgery at all. It's expensive surgery. You're talking anywhere from $80,000 up to, $400,000 depending on what part of the spine and how many levels are being treated. So the insurance companies, they're very greedy. They're not doing this for altruism. They're not denying spine surgery because they're trying to protect you from those evil doctors. They're actually protecting their bottom line. And they don't want patients getting spine surgery. So the insurance companies are against spine surgery to fix back and neck pain. All right? Most neurosurgeons and spine surgeons don't realize back and neck pain can be cured. So they're against it. You understand what I'm saying? So there's really a multitude of reasons, and there's a few others that are not as major, but those are the two major reasons. And then, of course, there's just technical knowledge by the surgeon how to fix a back, which very few have that technical knowledge because very few have been trained properly to do it. So when you talk about, well, my surgeon says that back pain is incurable, I have to take morphine the rest of my life. No, you don't. Morphine is not the right answer. Morphine is a narcotic. Again, I can't emphasize this enough. Narcotic painkillers are good for short-term pain. When a patient just had back surgery or neck surgery or hip surgery or knee surgery, you need those narcotics for about a week, and then you don't need them anymore. You need to take something else. But if you still have pain, that is. But the surgeon should be able to fix your pain. And when it comes to chronic back pain, it is curable and fixable. You must go to the right place, though. That's why Duke Spine Institute is available to do that. So no, morphine is not an option. It's eventually you're gonna build a tolerance to it. You're gonna have to take more pills, more frequent pills, higher concentration and strength pills. So it's not something you don't wanna go down that road. All right, and the morphine will never ever cure your back pain. Not like surgery can, not like therapy can. All right, what you need is a good doctor supervising your recovery from your back pain. Duke Spine Institute can do that for you. That was our last question. We'll see you all in 30 minutes for the next one.